What's the common denominator among these two?
Bilateral increased density.
Two different patients, same kind of density change, two very different problems as far as etiology, two very different causes. So here we have unilateral localized water density. Agreed?
Mm-hmm.
Here we have unilateral localized water density. Both of them have unilateral localized water density, which puts us where? Cat P, exactly. Is it consolidation? Is it atelectasis? Is it tumor? Is it pleural? Is it something on the external chest wall? How do we immediately get rid of external chest wall?
Because you can see the lucency.
With what? With mediastinum, chest wall, diaphragm. If we're silhouetting all those things, then it can't be on the external chest wall. It's gone. Easy. E's gone. So then we're consolidation, atelectasis, tumor, pleural. Now, did the mediastinum move? Because that's generally one of the first easiest questions to ask when we have unilateral density. Anything move toward it? If the answer is no, then there's a good chance it's not atelectasis, exactly. So, did the mediastinum move?
Yes.
Look at this one. Did the mediastinum move?
Away from the density.
Away from the density. So if it moved away from the density, something's doing what? Pushing. Something's getting bigger and it's pushing it out of the way. Which way to go on this one?
Toward density.
Toward. Now, both of these, the patient has atelectasis. But one it went toward. There's the trachea. There's the trachea. One it goes away. So this one, when everything's moving toward, is resorption. When things are moving away, something's getting bigger and expanding. And this are the same problem as far as the lung is concerned. It's just different what's causing the lung to collapse. It's just different. This is air, which means it's real easy to see the lung. But if you took this and filled this all up with liquid, it silhouettes this and you can't see it. So this patient has hydrothorax, a big pleural effusion, and when it's this big, it's usually infective. This one, pneumothorax, hydrothorax. And if this keeps leaking, it's going to push this over this way. It's going to push it away. This one's pushing away. Now this is probably a large suppurative effusion in the pleural space. So it's a big infection in the pleural space. It's full of what then?
Pus.
Yeah. And that's a lot, because it takes, just to get a pleural effusion up to here, where you can see it in the lateral angle, because the posterior angle's down here, takes 300 to 500 milliliters just to get it up to where you can see it. If it goes almost all the way to the apex and collapses the lung, and it's heavy, so it's going to push the diaphragm down, look at how much space there is in there. You could possibly have a couple gallons of pus in there.
Jeez.
Wow. Mayonnaise. Actually, they
Just a little straw.
It has
Just
it.
like the intern, you know.
Have it like the damn thing.
Well, just to get
It depends on volume.
Yeah.
sometimes you get a little
If
bit.
you increase this volume, it's going this way. At this point, yes, this will, the lucency will creep across the midline. It'll start compressing this lung and it'll push the mediastinum this way. It's the same thing here. If we had less fluid, the mediastinum could still be sitting normal. It's just there's more than what that pleural space can hold, and so it's starting to push the mediastinum. And somewhere, there's the diaphragm. Somewhere down here is where the diaphragm's going to be literally inverted. Because it's like, set a gallon of milk on your diaphragm and see what happens. The thing's going to go down like that just from the weight. Okay?